that already Dr. Nilesh Kapoor has shown, and the things were discussed by Dr. Mudit Sabharwal were already there in my slide. So I want to make some practical points here, and let's invite our panel here and do some panel discussion, because some of the things are remaining. So I invite all the speakers. Do we have everyone? No, Dr. Rakesh Parikh is not here, otherwise everyone is here, I guess. So please come on the stage. So ultimately, how practice growth can be there. Yes, Dr. Pragnesh Vachrajani, I invite you there, please. So, how practice growth can be there with the usage of AI by saving the time and reducing the manpower. But I don't know what I was thinking then, that who will do this work, that giving prompt to this Comet browser, that please do this work for me, please send this 10 follow-up reminders. For that I have to assign one man, and I should have one extra person who is technically sound, especially for AI, who is trained and who will be more, I feel it will be more expensive. What do you think? What you guys think for that? Do we have time every time that I want to give the prompt, and how it is giving the result? It is according to my wish. Is it possible?
So I think Dr. Nilesh should take the question, because now we are talking about ambient AI. The meaning of ambient AI means that the AI should fit into the ecosystem of the clinician and not the other way around. So maybe he can.
So the point that you are talking about is a design issue actually. So say I want to give a same command on a daily basis, like give us follow-up reminder to my patients. So what I need is basically a button on the home page, and I will just click on the button and the command goes. So these are all design issues. So when we build a software, when we build say all these kind of solutions, the design team basically conceives these kind of solutions automatically.
Right.
And when it comes to us in the form of front-end kind of design, it already has these features. Now the problem is that we are seeing again agentic AI in a very, very early stage right now.
Okay.
Going forward, what will happen is that they themselves will start giving us options of creating shortcuts. So what I feel is that this is not a problem to worry about.
So you want to say that ChatGPT is 5th generation, but agentic AI is 1st generation. So
So actually we are actually evolving into an ecosystem where there's going to be an autonomous functioning of the AI. So instead of giving multiple instruction, it will be able to pick up what is to be done next. That is the level of agentic AI or agents working in an autonomous way. So ChatGPT 5 already does that, because ChatGPT 5, you see, it's a unified model. So here it doesn't pick up whether it looks into academic papers or it looks into web search. It will, based on your question, it's going to look whether it goes into a more complex model or a simple model. And that's how agentic AI is supposed to work. So your browsers will also be kind of like that. So it will work on its own in the backend. The question is primarily going to be is how our work staffs can actually train themselves and evolve themselves. This is exactly what the way we have to look at.
So for work staff, everyone has different kind of work staff. If in my clinic, if you see, I have 3 diabetes educators who are nursing staff, 1 dietitian. I don't have any assistant doctor. Then I can't train that nursing staff. I know that their level, so how much I can train them. Yes, Dr. Pragnesh.
Hey, see, most of our staff, all the time, all the doctors are complaining. If I talk about the practical aspect, the staff is always busy on phone, watching YouTube reels and this and that. So they very well know how to use mobile and technology. So I think if you can give them a task on a weekly basis to start with, that you can start sharing some important information on weekly basis, give them a timetable, and make sure whatever they share, they show it to you before doing it. I think that gradually we can make them do it.
So it may take time.
Yes.
Maybe
because it is, as of now, it is difficult for doctors to convince to use EMR.
Right, very true. So it's a different question altogether. Right. So another thing coming to my mind is there any other tool, like very much live tool? Like we are using CGM, it is connected to some AI browser or app, where that CGM can predict hypoglycemia, and it will give you the alarm, and it will even ask you to do so, that you eat that much gram of carbohydrate before hypoglycemia occurs. Are there such live tools available? So,
Not that I'm aware of, but I also know that there are companies who are working, on creating such agentic AI platforms coming in the back, and it's just a matter of time when this will happen. In fact, we got a demonstration of something from the Sinocare,
ESD,
in the
yeah.
ESD, in the Sinocare team, that they have put in a back-end language model in the interpretation of the CGM. So I believe it's a matter of time. And the next step is connecting that with the clinical decision support system and the EHR, so the entire loop gets closed.
So I think the next Medtronic CGM will have a predictive analytics. Currently, the Libres we have, they are more reactive than proactive. But yes, there is a proactive component, because it also you can understand and analyze the trends. And if the first hypoglycemic event is actually tracked by the Libres. Next, the I don't remember the name of the Medtronic CGM, but the next CGM which they are launching will have predictive analytics.
Okay.
And the next series of CGMs which are going to be, even the Roche one which is there, it is also coming with the predictive analytics.
yes. So, another thing coming to my mind is that while we are using not only CGM but AID system, and can we rely on AI that much that we can allow them to titrate insulin? Right now what we are doing is through predictive model, it is not AI. So can we rely this? Because all the pumps are also coming up with AI system. So how much it is reliable? Anyone wants to answer? Like they want to give insulin themselves. We don't want to do anything.
Now there is an insulin pump which is a very small. It's called Medtone. So it was I think showcased in the last IDF or ESD. Probably you guys were there.
In
right?
ESD it was
ESD
there.
itself, right? So that's like a tube insulin pump, which is like a small tube.
Very small.
It also has, and I was reading about it. So that has a predictive analytics where the CGM itself can analyze what insulin dose and the patient requires and titrate the insulin doses as per the patient's requirement.
So I'll just add a point here. When you talk about the degree of autonomous functioning in the field of healthcare, this is a space that has not been defined yet. So when agentic AI comes in fact, this was one of the slides I showed in ESD. And again, even when you talk about responsible AI from the platform of the International Diabetes Federation, this is one question that comes, that how much of autonomy you want to allow the agentic AI to perform. So suppose there's a hypoglycemia, it gives corrective measures for correcting hypoglycemia on its own in a proactive manner. That can be allowed.
In
but when it is about correcting
preventive measures.
yes, in a preventive measure. But when it comes about giving correction boluses and changing insulin doses, will it should it do it on its own? Should it have the human in the loop or the clinician in the loop? I think these are the definitions will come, but these will come when you have each of these systems integrated. So you have the CGM, you have the pump, or whatever smart insulin pen you use, and you have the clinical decision support system and the EMR. So the entire four things connected in a loop. Then the question of autonomously functioning will come, and the question will come how much of autonomy we as clinicians or as a medical organizations we should allow.
So ultimately, it becomes like an open loop.
Yes.
It's not a closed loop anymore.
Yeah. So, Dr. Rakesh is not here, but as we all are writing our research papers from with the usage of AI, different AI tools. So how do you see? I still don't find it that refined, and still we need to humanize. I've seen many people promoting it like anything. Someone is not here, but I don't want to talk about it. But they are promoting it like anything, that yes, you should write only with the help of AI, and you can humanize and again and again with different tools, and you can use it. So how do you see it?
So I think Dr. Rakesh also tried to answer that question in a very different way, that there are certain journals which allow and certain journals which do not allow. So, and there are also journals like NEJM Journal of AI, which are kind of promoting the use of AI, and also they want to learn how AI is going to impact health in different ways. So I think there has to be a middle ground somewhere. you can use AI to refine your grammatical errors. You can see there was a point of time when Indians couldn't publish abroad because our English was not so good.
I don't think
Yes,
so.
yes, there
Is
was
it?
a problem. Yes, a lot of journals used to reject Indian papers because the English was not up to the mark, and they used to send it for revisions and again and again. So we have come a long way from there. So from that angle, if you see, then AI is an enabler. It's a great equalizer because now anybody and everybody can write a good English. From that perspective, it is very good. When I published my first paper, it was, I will tell you, it was around health policy and it was an Iranian Journal of Public Health and Management. And they sent it back thrice for grammatical errors, which I was not able to find out despite getting, you can say, specialized help also. And it was a nightmare for me because they were only pointing out grammatical errors. It eventually got published, but you go to the, if you will see the language, you will not be able to make a head or tail out of it. I can tell you with a great degree of confidence.
Right.
So from that angle, AI is a great equalizer. Now we do not have to worry about your language or literary skills, number one. Number two, a lot of people were not good at research skills to begin with. How to structure out their research in a proper fashion, how to write a basic structure, they were not well conversant with that. Again, AI is a great equalizer. You just ask what are the steps of doing a research, it will give you the steps of research. You can go step by step writing your paper. So a step by step instructions, or you can say a mentor who can guide you how to write a paper, it is spot on. Coming to the gray areas, like if you are relying totally on the output generated by AI, then again there are tools available now which the journals are using to find out if it is AI generated or not. The likes of Turnitin and others, they can pick it up if 90% is AI generated, if 70% is AI generated, if 10% is AI generated, and they are going to set up limits to that in the future. Just like they have got plagiarism checks. So 15% is the standard acceptable limit. Beyond that is not acceptable and the paper gets rejected.
Right.
So what I feel is that going forward, there will be checks and balances in place. Everybody will be using AI in some form or the another to either shape up their research or to refine their research, but relying solely on AI to generate outputs will not be acceptable to anybody.
Right.
I think the good content platforms, I mean, they also have AI filters, like ATTD or ADA. You send your paper, you send a research to ATTD, it will filter out the AI, and then they have AI barriers. I mean, you can't go beyond 8%. So it's like beyond that, it's not. And recently we had submitted and got accepted in ASN. The barrier was 30%. So it's defined in their requirements, and ultimately you have to go around that.
But I don't know about research paper, but when we draft an email or something with AI, you can tell AI that make it look like more like human. So do make some mistakes, so it looks like it is written by human.
So
I'll
even
just-
there are prompts available, write a human kind language.
Yes. I'll just, through all these years of doing workshops and everything in the last 1.5, 2 years, one important thing which I always keep telling participants is break the task into multiple tasks. Don't give a single task, write a paper for me. That usually does not work. So try to make AI work the way you will work. First is you will look for PICO, your research question. You will find, first you will understand the need gap. Then you will ask your research question. So do it in that stepwise. Then you'll go for literature review. Then you'll go for searching out, you're drafting the manuscript and things like that, creating a structure. If you use AI in each of these steps, it's basically you're working with an enabler. That's exactly what it is. It's not AI generated paper. It's you are generating the content with AI as an enabler. And I think every individual that's working on research should use it in this step. That's how you can use it responsibly. And I think.
So it's a similar way you work with a CRO. Absolutely. It's completely same. There's no difference.
Great. Another thing is I frequently hear one thing, and that is all statisticians will lose their job. Can it be done so that easily with the help of AI? Anyone wants to answer?
But if the statistician is using AI in their work, then why would they lose the job, right?
So
It's like all the mathematicians will lose their job when calculators were invented. It's a statement like that, but it never happens. There's going to be a role play change, and newer roles is going to be coming in. People will evolve as the technology evolves. That's what the history of mankind has shown us.
yes.
So every tech advance bring in new roles, and some roles become redundant. So if you want to say statisticians will be there just to tell which statistical test is to be deployed, I think that is not the right answer. That role will be redundant. What their role will be might be, see, we also need humans to take responsibility of the output. So if I am going to submit my research and my institution has a biostatistician and he has the responsibility to verify if the statistical output is right or not, that is his responsibility. There has to be somebody, a human in the loop is always required.
Right.
Similarly, in the CRO segment, you will be having clinical research, you will be having clinical trials. So you need somebody to take the responsibility for the veracity of the data. So there will always be need for data quality managers, the data collectors, the people who will be looking at how the data is preserved, how it is being analyzed, and how the output is being verified. So there will be these roles and they will always be there.
Great. Another and last question coming to my mind is, whenever we make slides with the help of AI tools and we ask for limitations, one thing is there, always it's there, and it is data privacy. And what do you say about data privacy? What to share, what not to share, and something related to DPD Act. Anyone wants to talk?
So I will take it up.
Great.
So see, what does DPD Act says? We need to understand first that. It says owner of the data is the patient or the consumer on whose body or whose data it is actually. So when we say, what it means is that, say a patient comes to your clinic and you take a blood pressure on his body, then the blood pressure is attributable to the patient or the consumer. So the data ownership belongs to the consumer. Now you cannot use that data without his permission. And when we say you cannot use, the hospital cannot use, the lab cannot use, the doctor cannot use. And all these three people believe that they are the owners of the data. So that's the first myth we need to break. Second is, anybody who is generating this data is a data fiduciary. What does it mean is that you have an added responsibility to preserve the data and also destroy the data if the consumer says so. Third, if you are going to do a research, then an ethical consent is must. So you need to explain to the consumer how the data will be used, how the data will be stored, and for what purpose it will be used. So suppose you are telling him that I want to do a research on, say, diabetes and hypertension, then you cannot use his BP for doing some research on nephrology. So these kind of also gray areas have been taken care of. And there is a penalty to the tune of 2 to 5 lakhs on the doctor, or you can say the data fiduciary. Although we do not have any precedence to this, like nobody has been penalized yet, but this is what the law says. Now coming to the point, how can we ensure data privacy? So the problem is that we Indians are illiterate around that. Everybody is using WhatsApp, everybody is using Facebook. Your all data is already gone to the multinationals and they are using it in one form or the other. Your Google is using your Gmail data and it's already part of their terms and conditions, and who the hell is going to read the terms and conditions in India? Nobody is bothered. So this data privacy is a myth.
True.
You go to a restaurant, how many of you are not giving your numbers? Please raise your hand. You go to a restaurant for a dinner, every restaurant today is asking for your number. How many of you have ever raised an objection to that?
And it's same for every field. It's not about only restaurant.
It's not about
yeah.
only our health. Data ingression, you can say, or data, you can say robbery is happening in broad daylight. We people are not bothered about it. Right. So government, whatever the government may do, nothing is going to happen because the people whose data it is, they are not bothered about it.
True.
So I'll just add one point to complement what Dr. Nilesh said, just to summarize and understand this. In India, as a law of the land, what we have is the DPDP Act. First, as clinicians, we should all understand and read on this act. It's available on the internet. We should go back, just Google search it or search it now on your AI browsers and summarize it and read it. It's absolutely a crime not to know the act. If you get penalized for a misconduct of the DPDP Act, then it's absolutely your fault. We talk about GDPR and HIPAA compliant. In India, actually, the law of the land is the DPDP Act. So this is something that we should all go back and see and read. There are some penalties which have been declared, and I think recently there was in a meeting where one of the ministers have given more clarity on the DPDP Act. And as we go about with ABDM and the NHA policies get coming in, the DPDP Act will also get implemented into the healthcare ecosystem. So as clinicians, patients' health information is a prioritized information, and we have to understand how we are utilizing this information, whether it is for research, whether it is for summarizing using the Comet browser, or it is for doing any sort of our automation task. We should know what we are doing. So please, let's go back and read on that, and let's be a little data literate, because at the end of the day, all that we are treating and living and earning our bread from is the data. That's exactly what's feeding us. So I think this is something that we should take back.
And just to add, ABDM compliance in itself ensures your all compliances. So if a software or if a service provider or a vendor says he is ABDM compliant, then we need not worry too much around data issues after that. Because ABDM compliance includes HIPAA compliance, it includes your fire compliance, it includes all this DPDP, and everything is kind of bundled into this ABDM compliance.
Great. So wonderful answers. Thank you very much, everyone, for this interactive workshop, and we can close this session and the conference.